Many of you have probably heard about the new Improving Access for Patients and Supporting General Practice Fund letter, BW999 from NHS England, that we're going to be talking about in this live stream. We're going to be covering the contents of the letter, what the potential implications for general practice are, and how you may consider responding to it, as well as everything else that you probably need to know. We're streaming to you live from the RCGP conference, so it's going to be a little bit different as usual, but we've got all the amazing content for you. So let's get cracking and let's enhance your primary care and learning. Hey GP learners, hope you're all doing well. So we're coming to you live from the RCGP conference just before the day kicks off. How are we doing there, Andy?
Yeah, it's good. It's nice to be filming in person with you here in the hotel room at the conference, which is why we're looking a little bit different on this episode. And I'm looking forward to getting through this letter. It's certainly created a bit of controversy and a bit of a buzz here at the conference.
And if you do want to get some of that context of how it's been landed at the conference, check out some of our earlier streams that talk a little bit about our experience at the RCGP conference. But today we're going to be focusing on this letter that's come down, released by our Health Secretary, Sajid Javid, on Thursday morning. It came out at 1 minute past midnight. And as many of you probably seen and heard in the papers and the media and stuff, it's landing interestingly, shall we say. The document itself, we're going to go through it in detail. And if you do want to access it, there'll be links down below in the descriptions that you can have access it. Or if you want, just search for BW999 Improving Access for Patients on Google. You probably should be able to find it. When you do so, you'll get something that looks a little bit like this.
So here we go. Yeah. So in usual fashion, we've been through and just annotated some notes to the letter. No replacement really for reading the letter yourself, but it's a good introduction to the letter. We'll look at the structure of it and we'll pick out some bits that we think are particularly salient and that need either action or things that are important to know about. We are not your commissioners. We are not NHS England. So there'll be a lot of local interpretation actually about how this all needs to be applied. So doing what we think it needs to be done will not get you through this. So just obviously work with your local commissioners and make sure that you're in line with whatever's agreed locally.
So I think the first thing to say is that this letter hasn't been received very well from many people within general practice. And interestingly, the organisations that are normally involved, things like the GPC and the RCGP, seem to have been surprised about the letter arriving. So there may not have been the usual kind of engagement we see with some of the previous funds that we've been told about. And yeah, the reactions are...
It's been interesting to see how it landed, actually, being here at a conference with some of the RCGP bigwigs. Sajid Javid was due to talk at the conference yesterday morning, and cancelled at the very last minute in order to go on the breakfast shows, I guess, and talk about this letter. The timing's interesting that it landed on the first day of the RCGP conference, and that Javid knew that was happening, I guess, knew he was scheduled to talk at the conference and changed his plans at the last minute, which I think is interesting. A theory I've got is that I think they probably anticipated that this wouldn't land well with general practice. And I know when health secretaries have been at the conference before, they've attracted a bit of a media circus around them. And I think there was perhaps a risk that media circus would be asking the GPs for their response to this letter because they were there with the GPs because they followed the health secretary. And perhaps the government anticipated there was too much risk associated with what those GPs might say. And they wanted more control over the sort of media release of this letter, and they achieved that better by not being at the conference. But that's just a theory.
We won't talk more about that, but we have had the opportunity to feedback on it, like we said on some of our other streams. In terms of the content of the letter, it's pretty much split up into 4 parts. The first part being just a summary, as per usual, that NHS England tends to give us, and buried in there somewhere is a thank you.
We'll have a look through these. The way these letters are written are interesting, I think. We're becoming a bit more attuned to reading them. And then the main meat of the letter in terms of what will happen and where some of the extra funding will be directed, and where some of the attention, shall we say, on performance will be directed, are in sort of 3 sections. So there's a section about increasing and optimising capacity. There is a section about addressing variation and encouraging good practice, which is perhaps the most controversial element. And then there's a very, very short section at the end about zero tolerance. So shall we dive in and
let's go for it, shall we?
Started.
Yeah.
So what did you make of the introduction, Gandhi?
Yeah, so it's a standard kind of NHS England summary kind of document. It sets the tone for the letter, talks about how mostly general practice has been doing really well, which kind of indicates that they think there's some parts that probably aren't doing so well. I think you've coined this phrase before. It seems that they write these documents for people that are not just general practice or commissioners and stuff. It's written for a wider audience, shall we say?
Yeah, I think it's written for multiple different audiences, I think, because everybody can they're trying to throw everybody a bit of a bone, really, in terms of how they write these days. So there are actually some very positive things that are said about general practice and the response that there's been to the pandemic in terms of adopting new methods of consultation. And they do acknowledge actually that numbers of appointments have remained high, or in fact increased from pre-pandemic levels. Interestingly, they talk about the objective evidence actually from the GP survey that satisfaction with general practice has increased to the year 2021, as in its better reported satisfaction levels, including with access in the GP survey this year compared to previous years. But then they do go on to talk about subjective experiences of GPs as reported in the media. There's evidence that all is not well with GP access, which is interesting. So those are the bits that the press can sort of latch hold of, and I think they're hoping
or that control, depending on your perspective.
Yeah, I guess, and they're hoping that we focus more on the positives. But again, I guess we've read the whole letter, so we're wise to it.
And then it kind of moves further on to talk about other aspects as well, Andy.
Yeah, we're just scrolling through. It's a little bit slow here. So they've been really clear in the introduction, that zero tolerance is unacceptable, and that there's been an increase in malicious and difficult interactions with general practice staff, both online and offline, and they acknowledge that something needs to be done about that, which I think is nice to have that in here. I think, and actually, it's more than nice. It's important.
Yeah,
so it's good that is in the publication. And then these introductions are often quite long, actually, but they're acknowledging that there are workforce factors. So they're exploring some of the factors as to why people are reporting poor access, and they're not saying that it's because general practice isn't open and doesn't want to do these things. They're acknowledging that there are real concrete factors behind it. There are workforce factors. They also acknowledge that general practice has done a lot to adopt the new technology models during the pandemic, and that many patients prefer their experience of accessing GPs in new ways, telephone first and online triage tools and electronic consultations, and that for many patients, they find that convenient and they like that. So they're not necessarily expecting everybody to go back to pre-pandemic methods of accessing general practice, which I think is interesting. I just picked up on, the wording's interesting. So a minority of practices are offering wholly inappropriate levels of access. So in places, it is actually quite strongly critical. If not the whole of general practice, then there's certainly a minority of practices, which I think is interesting.
I think it raises the question of how some of this documentation is going to affect those companies and those practices that are very much invested in digital first. So obvious examples would be things like Babylon, Push Doctor, those kind of companies where that is their delivery mechanism. It is very much and has always been remote first. But actually, over the pandemic, many practices have made that transition, and actually for their populations, it's working really well. They're getting really good feedback in terms of how that's working for their populations. But this document may actually say to them, that's not acceptable anymore, and you need to change it, even if they are having a really positive impact for their populations and stuff.
Yeah, I think a key sort of theme here, and something that's run through the conference, is this idea of getting the balance right between the newer ways of interacting with general practices and the surgeries, and the more traditional ways. And there's pros and cons. Convenience versus that relationship-based care that the RCGP goes on about a lot, and that is really, really important. And people don't really know where the balance is. And actually that is acknowledged here, and it talks about the RCGP working with them to find out what the right balance is. And of course, it's going to be different in different parts of the country and different practices. There's going to be no right balance, but I suppose it's just understanding how if your balance is right.
And I suspect that document that will come out from the RCGP is probably going to be very controversial, to be honest, because it's going to be really difficult, I think, for the RCGP to give a direction on what is appropriate level of balance, because the whole point of this is that it's very individual to the populations you look after. And I don't envy their position that they're going to be in, and I suspect, unfortunately, they've been painted into a corner here.
Yeah, I guess that's what they'll say, and they'll perhaps offer tools to help you understand your population and what your balance is. They were really quite negative about the letter yesterday on the stand. Martin Marshall said that this was, I forget the exact words, but I wrote them down at the time and did a tweet. But this was most definitely not the answer to the access issues. That's what he said about this document. So be interested if they play ball with the document.
Similarly, hearing that many of those that representatives in the GPC and stuff have not been involved in the actual content of this letter. So, there is a question of how much of it has actually been agreed with our union and stuff. So there are some questions. But let's move on to the bigger sections of this. So the first part is talking about increased capacity and optimizing it in terms of general practice. And it kind of splits itself into two main categories, doesn't it, Andy? The first one being about looking at providing this additional funding. And yes, there are definitely debates about how much of this is actual additional. We get winter pressures funding seemingly every year for the past few years. This is just basically what that is. It may be a little bit bigger than previous years, but actually, this was funding that was likely to have come anyway. It's not extra funding per se. But the first part does focus around improving capacity within practices themselves. So, what additional clinical capacity could there be from practices if there was additional funding to help with that? So I guess the one example we've had is if you've got part-time workers, GPs, for example, or other types of nursing clinicians and stuff that do work part-time, that might have the capacity to work extra, could they do so over winter to provide that additional capacity in their own practices or network areas and stuff?
Yeah, given that there will be additional money to help pay them, that's not going to be out of your core budget that you previously planned for when you're employing those staff. I think other interesting thoughts are, it talks a lot about sort of digital locum pools, doesn't it? Which, again, it's not quite clear what that is. And it could be two things for me. Part of me imagines, a pool of people that are sort of sat remote working that can be sort of deployed to remotely help practices. We'll come to the 20%, but some of these practices that are in the lower sort of fifth of performance on the various metrics that they're deciding to track in terms of access. That's sort of one thing I see. The other thing is something that might be much more practical in terms of, if you've got a primary care network or a geography and you create, a WhatsApp group of people who might be interested in doing extra sessions ad hoc where required across a range of practices, and the practice managers can go on there and, access these people, perhaps with some ground rules about how much people are going to be paid to stop people going to the highest bidders, so to speak. But a digital locum pool can sound quite grand, but I think actually just using existing communication tools, a geography might be able to slap something together that works, fairly quickly. Whether the hours are there is the other question.
So I guess the key challenge, as many of us know, whilst it's nice that there is some funding now being made available to help with the pressures, the key question is, where's this workforce coming from? And that's the big question I think many of us have. I guess the cynic may view this as a way of funneling money to particular companies that have prioritized digital first and may have the additional capacity. Is this a way of saying that actually you can spend that money with those kind of companies that may have that resources and stuff? I think many would prefer that to always be locally resourced people, because then that can hopefully lead to better engagement in that kind of stuff. But I don't know, are we cynical or not?
I mean a lot of these companies would be well placed to develop the former of the examples I gave, in terms of a remote workforce that can be deployed anywhere in the country according to demand, almost like this smart electricity grid, isn't it? It's interesting that we're talking about these sorts of solutions when actually I think the main thrust for most of the general public is about face-to-face appointments with their GP. And we're talking about digital locum pools and things like that, which is interesting. Do you think many retired geriatricians will be coming back to work in general practice? That's the other example.
Really interesting example they've given, that apparently there's a pool of retired geriatricians that may want to come and help work in general practice, even though they can't do that because they don't have a CCT or performers list in general practice. but might still be able to do something. I don't know. Are you a retired geriatrician out there that's itching to come and work in general practice? If you are, please let us know in the comments, because I've not heard of any, to be honest.
Yeah, and we're obviously making it sound so attractive. It's not necessarily that
absolutely
bad.
But that's part of the focus. And I think one of the actions, and again, this is based on your local area and stuff, but one of the actions I would recommend all practices that are watching this is do have that kind of quick chat with your staff. Is there anybody that's capable of doing additional work over the next few months and interested in doing so? Because to be honest, that is likely to be the only way you'll directly access any of this funding from a practice level, despite the fact that made papers will say that GPs are getting 250 million and all that other crud that always happens. Let's be honest, the letter is quite clear. This money is not coming to general practices, it's coming to primary care to support the winter pressures, and the only way a practice will directly be able to access that is if they increase the capacity of their existing workforce, which, as we all know, is going to be difficult, but that is the main route. It does then talk about the second plan of improving access and stuff, which is about looking at the local area. And I suspect this is where most places will be focusing the potential use of these resources and stuff.
And I think as we're going through the letter, I think it's probably important for people to think about, okay, what's their action plan? What's actionable from this letter? So what we're talking about, because there is some funding available to support access. How new it is, that's another question. And the locality team, we'll get to this, but the ICSs and the CCGs and so forth need to submit a plan by the 28th of October outlining how they will deploy their additional resources and how they will, they need to evidence the number of appointments, the amount of additional capacity that will result from it. So that's a pretty difficult task for them. So I think there'll be a period when they'll be receptive to ideas and thoughts about how the money can be spent, which is where this next section comes in really. Support within the system, and it looks like it can be deployed fairly flexibly. So I saw this and I thought, actually, we've been struggling to get funding for estates for a hot site to see hot COVID patients and RSV type patients over the winter. We know we'll be seeing a large number, so maybe this is a place that we can fund some of that estate and maybe some of the capacity to pay for people to work at that site, to take some of that work away from general practice and help. So I was thinking about that. Any other thoughts that struck you in this section?
I think one of the key things is focusing on either using existing resources to enhance them, so things like treatment centres, walk-in centres, out-of-hours centres, that kind of stuff, or like you say, creating rebooting possibly, or creating new ones like the clinical management centres that we had when COVID was rife and stuff. And let's be honest, COVID is still here. We've heard yesterday that there was 40,000 odd new cases in 24 hours, so it's not going away. The complexity of how flu is going to affect us in the winter cycle is obviously a massive concern for many people. It'll either go really well or really badly, to be honest. And then RSV, as well as various other respiratory viruses that are causing the problem. And we know it's going to be this upper respiratory illness that's going to be the big challenge, because it always is in winter, and it's the thing that puts that extra pressure on everybody. So how do you see those patients safely and effectively? Even if they were to get rid of social distancing, that doesn't change the fact that they're going to have vulnerable patients in our practices. So how do we manage that flow of patients to make sure things work safely? Is it that you have a separate centre where these patients are seen? Is it that you invest potentially in technology that can help to do rapid diagnosis? So some of these, CRP kits, other kind of kits and stuff that can help you establish, is it viral, bacterial, that kind of stuff. That may be something to consider. I don't know if that's funding's going to be able to be used for that. But, that there are options, I think, and it's going to be interesting to see how the centres are going to be able to respond. Estates is a big one, as we know, and tackling the estates challenge may help to make some of this more viable. Big question is still going to be workforce, though.
Yeah, I think that's the elephant in the room here, isn't it? And just not to spend too much time going back to the introduction, but they talk about the workforce and the measures that the government has put in place to increase the numbers of GPs, and how that has increased and so forth. And, they suddenly want to increase capacity again, and the behaviour is like that can be done by just throwing money at the problem now, and that's not the case. It's a
non-recurrent funding.
Oh yeah, of course, non-recurrent funding. Someone was talking to me, I don't know if it was you, Gandhi, or if it was somebody else at the conference, but they were saying, it's another example of a supply chain issue, neglecting supply chains for too long.
Yeah.
Our supply of GPs, practice nurses, and actually a lot of these other allied health professionals, which are supposed to be quite numerous, but actually we're finding really challenging now to recruit into primary care networks like clinical pharmacists. There's not necessarily the numbers out there of that class of worker either. The country's neglected its supply chain in terms of workforce for a long period of time, and that's coming home to roost along with the other supply chain issues.
Anyway, we need to get cracking on through the document, so let's go to the next section. So I can't quite see it clearly, Andy.
Yeah, so we're just sort of, the document that we have on the screen is just sort of still plodding through the ways in which the local commissioners are going to deploy this funding. So it's been clear that the local system decides how this is going to be spent, and that their deadline is the 28th of October to have the plan, and they have to quantify the capacity created. So I think if you're having conversations about how to get access to some of this money, speak that language and go to them with things where you can quantify the number of appointments, because I think that's the language that they're going to need to use to the Department of Health to justify the spend.
And that's probably the second action that we are going to suggest to most people, that by the 28th of October, the systems have to give their response to NHS England as to what they plan on doing. That will be fed up through your PCN clinical directors. So unfortunately, it's an unbelievably short period of time. It's basically, 2 weeks for you to get that information back to the centre as to what is possible and what that might mean. And unfortunately, that's over the half-term period, which is not helpful at all. Fair enough, they want to have this impact before winter comes, which obviously no one can stop that coming.
Yeah,
I feel like we're in the Game of Thrones, to be honest, a little bit, Andy.
Winter is coming.
Winter is coming. But yeah, effectively 2 weeks to get some responses back to the centre. So your PCN clinical directors and their teams are likely going to be knocking on your door to ask for a response for this particular part, because that's what everyone's going to be working towards, is that 28th of October deadline.
The next bit just talks about what the government has been doing to increase the numbers of GPs, etc., etc. Some people may consider a lot of this spin. I seem to see various different figures coming out from different places about the number of full-time equivalent GPs, such that I don't know what reality looks like anymore. But it feels like there are fewer, so I'm inclined to go with those figures. And talks about increasing numbers of other roles in general practice, which I think there has been an effort to bring other roles in. So I think that's
interesting. It mentions that particular part about the 15,500 commitment that they've got to have of ARS roles by March. So it'll be interesting to see whether or not that target is reached by the government, or whether yet again it's a failed target.
It's difficult to recruit on the ground, isn't it? It's difficult to actually follow through and meet your recruitment targets in primary care networks, I find. Talk about cloud-based telephony. So
I think this probably surprised a lot of people that it came up. Unsurprising in some ways, because actually, those practices that are using older-fashioned technology to manage their lines and stuff obviously have that challenge that they've got a limited way of bringing in phone lines and contacts and stuff. So moving to a cloud-based one, which can be expanded and contracted as needs be, clearly sounds sensible. I know we've had chats with various companies that provide really effective services and can really, help practice. And I personally believe that in terms of how they manage their incoming workload and outgoing stuff. And I think one of the things I wanted to reflect on is that, what isn't mentioned in this is the fact that the workforce itself may be really challenged additionally because of illness and that kind of stuff. So having a better capacity to work remotely, even though this letter is always focusing about face-to-face contact, actually may mean that practices have a bit more resilience in terms of how they cope with the winter pressures. We saw this during COVID, many practices having to work from home. That's not going to go away this winter. So, having a system that allows you to easily do that, and more importantly, the funding to allow that to happen. Yeah, positive step, actually. It is one of the key things that seems positive. The downside is the time frames it's going to take for these things to have an impact. It's going to be really difficult.
Absolutely. And then they also talk about making better use of community pharmacies. So we've got the opportunity to sign up to the community pharmacy referral scheme, which is the 1st of December.
Yes. So you have to sign up by 1st of December. It is a part that does bring some additional funding. Now, whether they're conflating the two different pots of funding, I'm not quite sure. We haven't been able to figure that part out because it is including the IIF fund. So if you do sign up to the schemes, then you do access some of the IIF fund money to help with that. And it is a PCN direction, DES direction and stuff. But whether this is completely, I don't quite know, but it is extra funding that will come to practice if they sign up to it. Implications of that is also for each place to note. I guess if you wanted a third action, this is really the point where you need to have those discussions with local pharmacies, to be honest, because it is the cooperation between the two that's going to mean this might work effectively rather than it end up being work dumps, which I think is what many practices are potentially concerned about.
Yeah, and the local pharmacy committees are normally very receptive if you approach them. So that's the sort of pharmacy communities version of the LMC, the LPC, and generally speaking, I think they've assigned community pharmacists for each primary care network community. So there should be a point of contact, there to help you liaise in with your local pharmacies. I've always thought there's a lot of promise in these sorts of pharmacy referral schemes, but yeah, it's very difficult, I think, to shift two things. One is patient behaviour and patient beliefs about what the pharmacist can and should be dealing with. And then also sometimes there's a little bit of a shift required in terms of the pharmacy community. Not all of them offer these services. It can become confusing if not all of the pharmacies offer the service, and that the experience is different in different pharmacies. That can contribute to the difficulty in making this kind of cultural change. But there are other places in the world where people will routinely go pharmacy first. So there's hope that we can gradually shift the public in that direction. So I think that's promising, but is there actually any additional funding for that within the document, or is it just paying lip service to something they were already doing? There we go. Oh, contraception by community pharmacies. I think that's for certain forms of contraceptive.
I don't know on this one. But we had this in the conference yesterday, didn't we?
We went to a talk about it.
So, yes, patients can now potentially access some types of contraception directly, but they still have to pay for it. And where would they rather go? Would they rather go to the family planning services and general practice to get it for free, because it is still free on prescription, and quite rightly so? Or are they going to go to the pharmacy? Well, I think the number of patients that will likely to do that is going to be exceptionally small. But hey, that's a separate thing for big great if they could get it on an FP10 from there. And they also talk about the conference. Actually, we often use that as an opportunity to have other conversations around long-acting reversible contraception and things like that, which would be lost, and that would be a shame because those are effective measures. Okay, so COVID vax.
Yes.
I think the big take home from this particular section is the fact that whilst it acknowledges that general practice in some way acknowledges that general practice has been doing an amazing job with COVID vaccination, it does like to reinforce that you can't do that in place of the routine job. So even though the COVID vaccination scheme has worked amazingly well because of general practice, it's kind of like, well, you need to make sure you're doing the day job, because if you're not, then we don't accept that as an excuse. That was my interpretation.
Yeah, I highlighted that in red. I thought that was interesting and strongly worded within the document. They go on to talk about reducing administrative burdens on general practice, and they are committed to reducing bureaucracy, etc., etc. They particularly single out fit notes, med 3s, and DVLA forms as particular examples. I mean, we could probably produce a long list of other things which feel inappropriate and take time, both things that patients ask for themselves or from their employers, and things that come from other parts of the government in terms of providing reports about sort of fitness and capabilities for benefits and things like that. But they're going to be looking at that and putting in other systems in place and encouraging hospitals to do more around fit notes and so forth.
So the confirmation that fit notes can be electronically signed from April. Why they can't just make that happen sooner, I still don't know. This is an ongoing issue for nearly 2 years. The fact that other roles may be able to do fit notes as well, pro-con, there's a different debate there. As you said about DVLA, about the certification of particular conditions where they can continue driving and the implications that has for them. And, discussions with hospital teams about making sure that they're not putting unnecessary administrative workload back to general practice. It's a constant issue. Clearly, secondary care is overloaded as much as primary care is in some ways. But it's about communication, to be honest, more than anything else. Yeah,
and they're placing some emphasis on secondary care providers being required to address processes that generate avoidable administration burdens for general practice. And I think they're quite open-minded about that and think about making sure that patients leave hospital with a timely discharge summary that is good quality and with appropriate medications so that they can be added in a timely fashion to their repeat prescriptions, and patients aren't immediately running to us for medication. That kind of discharge handover bit is an area
I mean, for me, the big one that would make an instant impact is not discharging patients if they haven't been able to contact them for their outpatient clinic appointments. The number of patients where that is a growing issue because of, secondary care have difficulties managing remote care. I think that would make an instant impact, that removing the fact that they can be discharged after 2 attempted calls, for example, which is what our local process is, would absolutely make a massive difference to everybody. But hey, we're not in control of this.
Yeah. This next bit, I'm not sure I fully got my head around, Gandhi. It's just around the sort of QoF and PCN specs are sort of, they've been deployed, they're advancing, they are not on hold. We have to comply with those, but they sort of said they're not looking to place any further QoF requirements around the access issues. But later they are introducing a QoF QI point about it later in the document. But so I hope you understand that, Gandhi.
I think this section just identifies 2 key points. Number one, there is no plans to repurpose existing QoF into access-based QoF. Okay. Secondly, there is no plans to remove QoF monitoring. Those are the 2 key points I would take from it. You're right, it does talk later about QoF QI, which is the way I think they've fudged it, to be honest. So they're not calling it QoF, they're calling it QoF QI instead. And whether that replaces the other QoF QI work that we were meant to be doing, that doesn't look that way. It's additional, as usual. But yeah, that's the key message I would take from that, because it is a little bit confusing, because they say we're not going to change QoF, but then they're changing QoF. But hey.
That's fine. And extended access can stay with existing providers and doesn't have to move under primary care networks if you're.
I know some places are really annoyed about this, actually.
A longer period of time.
Yeah. So some places are clearly really frustrated about this because they've been working towards more PCN-based extended access and stuff to reconcile care and move plans forward. This has then delayed those plans even further in some ways.
Where the PCN can demonstrate its readiness, commissioners are encouraged to make local arrangements for a transition of services and funding to PCNs before October 2022. So there might be hope for those areas, but it might not be a priority for commissioners to move forward.
I can understand the reason, so try not to upset the apple cart when they're asking us to do additional things, and let's be clear, they are asking us to do additional things. But at the same time, as I said, I know there are some areas that are really frustrated because this deadline keeps getting pushed back and is creating additional workload for those particular areas. So yeah, difficult.
Yeah.
We then get to the big section.
Yeah, this is the most controversial area, isn't it? Because it's all, Part A is quite nice. It's additional funding for additional things. So this is address variation and encourage good practice. So this is where, this is really quite controversial. Shall we just work through it, Gandhi?
So I'd probably describe this. We've kind of had a stale carrot, and now we're getting the big, huge stick.
Yeah. Okay. So fine. And practices need to have done an exercise to assess the way that they're meeting patient needs in terms of appointment by the end of October. So make sure you have that conversation and that's documented. Someone might ask at a later date to demonstrate that that's happened. The RCGP is going to work with NHS England and the Department of Health in order to agree what the right balance of face-to-face and remote appointments are and what the right level of access is. I say, given the RCGP's response to this document, it'd be interesting to see if they continue to play ball with it. I think they have no choice.
I think they have a choice. Whether they choose to exercise that choice is a different matter. But I can understand. I think the RCGP, by the sounds of it, have been painted into a really difficult corner. Because I am going to be honest and say I cannot see how they can make this work effectively without annoying everybody, to be honest.
It's really tough for them, isn't it? Because if they don't cooperate, then they just do it without them.
Yeah.
And you get something that is not influenced by the body that represents standards in general practice.
Yeah.
So it's very difficult for them not to be at the table, but equally they'll be criticised for being part of this. Very difficult. I think they need to play ball with it and minimise the damage minimisation, really.
I mean, the clear thing is NHS England are probably going to ask for a number, and the reality is any number they give is going to be wrong. So that's the difficulty.
Yeah, they need to come back with some sort of nuanced answer, maybe provide the tools to help understand the needs of local communities. It's going to be different in different places and different types of communities. It's a really difficult challenge. They're just highlighting that the QoF QI for access is coming. So that's going to be interesting. A role of big data analysis, will be part of this. So that's interesting. Yeah, so real-time patient satisfaction measures. I thought this was interesting. We were asking for this, Gandhi, a few weeks ago.
Yeah.
When we were looking at the GP survey,
yeah,
and saying, okay, it's retrospective, the sample size is quite small, the data's old. You know, by the time it's published, essentially, and we had all sorts of issues with it. And they're talking about collecting real-time satisfaction data. What did you think about it?
I think in some ways it's a positive compared to the existing mechanism of the survey, which is, as we talked about in that episode, haphazard at best. I think the frustration of this is that we have no control of the questions being asked. So, you know, the wording, all that kind of stuff, none of that seems that it's likely to be discussed with general practice. It's going to be instructionally made. And you know, that has a different type of narrative compared to when it's done inclusively of practices, so that they can get good information. Yes, there are questions, you know, if you wanted to, that you would want to ask about access and service and that kind of stuff. Fine. I don't see any other area of government where this is being done. So why are we being singled out again?
It's really interesting, and this part or sentence 38 here was interesting. So we've all been used to using the coronavirus dashboard. It's a really good visualization of real-time data coming from the health service, and they're talking about working with the creators of that to create a general practice dashboard to allow anyone to understand different aspects of general practice performance, which I think is quite powerful. But also quite dangerous. And I think with anyone, we can read general public, but also the press. And I read this and I thought, this is a really cheap way for people to get cookie cutter stories about the NHS. Everyone, you know, general practice is it's the bit of the NHS that everyone touches the most. So it's quite emotive. Most people can relate to stories about general practice. And that's why we see so much of it in the news, in the newspapers. I think, you can't talk about, rheumatology services or something. It just doesn't have the same traction with the general public, because not everyone needs to talk to a rheumatologist. Everyone contacts their general practitioner. But I've seen how even locally in Nottingham, when the GP survey data comes out once a year, there's always an article. These are the top 10 practices in Nottinghamshire. These are the bottom 10 practices in Nottinghamshire. I hate to think what's going to happen with real-time data, where they can cut and slice it in all sorts of directions. They can have a general practice story every week of the year. But there we go. But on the other hand, if the data's good, I mean, if it wasn't available to the general public, we could probably learn a lot from it and find it very useful, reflecting on. On the other hand, I don't know, if the data's there, shouldn't it be available to the general public?
I think it has its uses. Like I said, my concern is the fact that it's the wording of the questions, because often it's the way you ask a question. So, it is likely to be, the question will be, have you had an appointment, rather than contact. I know it's a personal bugbear I have. Contact with your practice is similar to an appointment, and actually they mean two different things to the patients, generally speaking. So, it's just understanding that difference and things.
Yeah.
But we need to move on.
So, all ICSs should start an immediate exercise to look at the following data and intelligence of their individual practices. And they need to consider these 5 or 6 points. So this is the bit looking at the 20% rule.
So this is section 42. This is probably the one that most of you are going to have umbrage with, shall we say, and it definitely is challenging. It's the area I like to call the 20%ers. I'm going to coin that phrase. I'm going to trademark it, because it's going to come up on things. But effectively, it's looking at the the practices that sit in the lower 20% or the lower 5th centile of a variation in terms of particularly 3 key areas. So number 1, practices that are providing less appointments compared to pre-COVID situation for that time of year as well. So it is a fluctuating thing that will be used to compare against. 20% of practices that have the most number of one-on-one contacts in hours, and the 20% of practices that have the most ED attendances from their practice lists and stuff. How this information is going to come through is not really clear. I wasn't aware that this information was available easily. And the fact that local areas are now going to have to look at it. I think 111 you could probably get, because there's going to be the log there. The ED one is the one that really I think is going to be really challenging, because would you consider an inappropriate ED attendance? That is an absolutely perspective thing. And I don't, we always talk about inappropriate referrals, and, this is something that you cannot do from just a cursory audit and database.
It doesn't, the word inappropriate isn't in there. It's just 20% rate, the highest, the 20% of practices with the highest rate of A&E attendances compared to what would be expected, which is probably a locally generated average, I suppose, for most areas. So it's even worse than that, Gandhi. And I know it's really difficult to control, to take action about your practice's A&E attendances, because we try, there's been A&E fire exercises.
There is no mitigations for obvious challenges. So, for example, if your practice is right next to an A&E department, there is a good chance that some of your patients are more likely to use the A&E services compared to practices that are significantly further away just because of distance issues. If you work in an area of higher deprivation needs, where actually the needs of those patients are completely different, there is likely to be a higher use of patients because they come from different healthcare systems. For example, if they're from abroad and non-English speaking, so therefore their view of how to use the system is different to many other patients and stuff. There is no acceptance that that's going to be an issue. I mean, I would not be surprised if in our area, those practices that are probably more likely to be in that lower 20% are likely to be the practices of high deprivation and inner city practices and stuff as a result of that. And that's expected, but there's no mitigation for those obvious challenges that are going to be there. So,
Interesting.
I have real issues with this, and I think many people quite rightly do. And then, like I said, there's a really big stick. The stick they're using is the threat of the CQC inspection.
Yeah, there's going to be more intelligence sharing with CQC on these issues, and from CQC to local providers about feedback that they receive about care.
And there is a line somewhere, if I remember rightly, about unexpected inspection, unannounced inspection, sorry. I can't remember where that was, but I definitely remember reading that.
I haven't seen this bit of it. I think it's in there. People have been talking about that line.
Yeah.
And they need to finalise an initial list of these practices. And then they need to take immediate steps to help remedy the action. And they need to do this, I think, by the 28th of October as well. Identify the practices. So, so that you can't really get yourself out of this 20%. If you're in it, you're in it. Which, wouldn't it be nice to be given advance warning so that people could be motivated to change the things that they want to change before they come at you with a stick? Although I think the action that's taken will be done locally, so different areas will, I suppose, have a different kind of emphasis or approach. I know we were on a call sort of locally with our CCG this morning about this letter, and they were making quite supportive noises towards general practice. So it seems like the initial response from local commissioners, at least in Nottinghamshire, hopefully, will be a supportive one. But it's interesting and sort of quite scary, I think, for some practices.
Agreed.
I've got a feeling we might be in the 20% for some of those. A&E attendances is a challenge, for example, for us. And then, so what happens if you're in the 20%? It's actually a little less detailed about that. So they talk about different things that can be done to help. They talk about partnering with other practices for support, partnering with federations and primary care networks. But they do talk about contract sanctions and contract enforcement if things cannot be remedied. So there's a very big stick there.
And I think this is unfortunately tarring all general practice with a very small brush that is actually probably genuinely applicable. There are unfortunately going to be some practices that may not be doing everything they could do, and there may be a variety of reasons why that's happening. But tarring a lot of practices with the same brush, which seems to be what this is going to be really challenging. Leaning on your neighbour practice to help you. Well, if your neighbour practices are similarly struggling, how's that going to work? Your federations are likely to be already working at capacity. How are they going to increase that capacity? And again, this comes back to the question of workforce. Where is this workforce that we can miraculously pay to work and stuff? Actually, that's the big challenge and things. But I think,
I think for many practices, the reason why they will be finding it difficult to perform on these metrics are not simply because they're not aware that they're not ticking the boxes and they haven't, thought about things that they could do to improve their access. Some practices try very hard, but there are factors particular to their population, or just that the practice has been struggling for a long time from a recruitment or partnership perspective, and those aren't easily remedied.
Yeah,
it's really difficult to tackle. But another angle I was looking at this through Gandhi, and these are probably my sort of rose-tinted glasses, was I think a lot of this might map to inequality.
Yeah,
I'm thinking, and that practices working in areas with high information or populations that are difficult to serve for all sorts of language or other issues may be struggling on a lot of these metrics. And actually, if this is handled right, and this is a way to direct most of the additional funding to those 20% of practices where they're struggling, to achieve an improvement for those practices and an improvement for the patients, this might not be all that bad. Put my tin hat on, wait for the arrows and the stones to come.
I think we'll have to wait and see.
I think that is optimistic, but we both work in deprived areas, don't we? And one of the difficulties is sort of motivating the system to redistribute funding to address those sort of systemic inequalities, and this places a priority on action on something that I think will probably map across to inequality. So I'm just interested to see how that angle plans out.
Next part talks about
the plan. So it's basically we're coming towards the end of the document actually, and it's just sort of clarifying that the local system needs to submit a plan and giving the various times that they need to do it and what that plan needs to contain. So I think this is worth looking at, so that you can speak the language of the commissioners when, as a primary care network or as a practice, you are saying how you can help them solve this problem and attract extra funding. So they are wanting to try and achieve all practices achieve at least pre-pandemic levels of activity. Okay, fine. Particularly, I think with regards to what does it say about face-to-face appointments? Oh, excluding COVID vaccinations. Fine. You often see those lumped in with the appointment figures actually, and it does distort things and make things a little bit difficult to understand, in my opinion. They need to increase overall appointment volumes in general practice and ensure appointment levels reflect the full deployment of ARS staff. Okay, increase the proportion of face-to-face appointments with GPs in the system. So where's the baseline for that?
Don't know.
It doesn't say, but they need to increase the proportion of face-to-face appointments with GPs in the system.
And this is the interesting thing. I don't know where the original baseline data is coming from, because as far as I'm aware, that baseline data was never captured.
Using the same methodology that we're capturing
data now. It's a different methodology we've got now. So how are they going to capture that data? Because the GPAD stuff that many of you probably remember doing earlier in the year, and that we've helped create guides and stuff and understand what you need to do, doesn't specify GP appointment versus other clinician appointments like your nurses and that kind of thing. It does for particular roles like ARS roles, which are obviously non-GP roles because that's how the funding works, but it doesn't in practice specify the difference between a GP versus a nurse versus a physiotherapist for in practice, for example. So I'm slightly confused how they're going to get the baseline data for the types of GP-based appointments that they've had, or whether they're just going to say, well, we're just going to assume it was this amount.
I mean, a lot of this will, in the end, be theatre.
Yeah.
I think for the wider media circus, we'll probably find that it's achieved. Just like they've got the extra 15,000 GPs or whatever.
50 million appointments and stuff.
We may find that they magically just say they've done it. Minimise 111 calls and avoid late attendances.
So that's a metric they could look at.
These are what the system needs to try and achieve.
Yeah.
So full use of 111 dispositions sort of sent in, rerouted to primary care.
Yeah.
I'm not sure that works all that great actually. I'm just thinking about the quality of the sort of thing that lands with the on-call via 111. It's an area where there's a lot of potential, I suppose, and it could be improved a lot, is what I would say. And support all practices by December to sign up and make use of the community pharmacy consultation service for minor illnesses, which I think, again, there's good promise there, I think, if your local pharmacies are able to deliver well on it. And the systems will be required to produce a fortnightly update. Okay, that's not us doing that, although we might be asked to contribute to it, but I hope a lot of the reporting is on remote data collection. And systems will need to take immediate action to prioritise and support this work. So this is really for the system as well as us, isn't it?
It is.
And then the last section is really quite small, really. It talks about zero tolerance and abuse and public communications, which is nice to see that on there, which I think means social media bashing. Does that extend to negative things in the wider press? I think probably not.
No,
it'd be nice if it did.
No, I don't think it does. I think it's important that this part is here. It is unfortunate it is the smallest section, and it is unfortunate that there is not much detail as to how they plan on doing this. They're just committing to do stuff, and unfortunately, my confidence in the government and the NHS England committing to do stuff is at times waning. I think one of the key things it does mention is that they are looking at increasing the terms for those accused of healthcare. I've forgotten the exact wording, I'm afraid. Aggressive actions against healthcare staff. So they're looking at increasing that. It reaffirms in writing the commitment that there is a zero tolerance policy in the NHS, and that includes abuse and violence, I think is the term, if I remember rightly.
I'm trying to zero in. I'm sure you're right though. But yeah, they're looking at it.
52 was it? I think it says the wording.
It's 54 talks about working with the Crown Prosecution Service and Department of Justice to bring forward new legislation for the maximum prison sentence for common assault on NHS health workers. So that's, I suppose, singling them out like they do police officers.
So I'd probably suggest practice focus on one of the earlier ones. It talks about the line about abuse versus abuse versus violence and stuff.
51.
51, that's the one.
51.
And remembering that verbal abuse is abuse. So that is the definition of abuse itself. So in that respect, those patients that do feel that they have some right to be verbally aggressive with our staff, and the key emphasis I would put would be for reception staff, who absolutely soak up so much more than general practitioners and the clinical staff will do. A reaffirmance that for those that practices have the right to do something, and you should be doing something, because otherwise it continues the behaviour. There are always going to be times where there needs to be some grey areas and some compassion given, because the situation may be like that. But the affirmation that absolutely our reception staff in particular should be protected from a lot of this stuff. And it does state it's not just clinical staff. That's the key thing. And that's the part. It's nice to see that worded. It would have been nice if it was a bit clearer, and absolutely the commitment of what they're planning on doing being better. So committing to a campaign to inform the public is...
Yeah, I would say two things about this section. I would have liked it to have gone a little bit further and focused a little bit more on the public communications element. It's asking too much, but I think a lot of harm is done to the therapeutic relationship between patients and their GPs, and the health and well-being of general practice, and actually recruitment into general practice and so forth, by media stories about general practice. They were never going to address that in this document, but if the government did something to address that, I think that would be really, really fantastic. And the final thing was sort of this commitment to work with patient groups to work on the communication about how people access general practice, because I think this is almost one of the key problems here. Because when I talk to patients, they don't understand how general practice has changed its access model. People think that general practice has been closed. It hasn't. And I think at the heart of this, when people ring up and they say you can have a telephone appointment because you can't come in face to face because of COVID, infection control issues and so forth, as it has been earlier in the pandemic, what people have heard is, you're telling me I can't see my GP. And the reality is, I think for most practices, if that conversation took the patient and the doctor to a place where they needed to see the doctor for a physical examination, or a closer exploration of mental health issues, that they would have been seen face to face. People have always had access in most places to a face-to-face appointment if it's needed, but I think people haven't understood that, and that's where a lot of the damage has been done. So this is quite an important part of the document. It is for me, and I hope people pay attention to that part.
And it's not just the type of contact, it's also the people that you're contacting as well. We now have a much more diverse workforce that works with us, and the view that I'm not seeing a GP, that's not wrong sometimes. Actually that's the most appropriate thing. I know for a patient with musculoskeletal pain, for example, they are far better served by seeing often a physiotherapist in terms of first contact than myself, because they can also do the interventions to help that person understand how to fix it, whereas I can't do that. I can diagnose the problem, I can give them a plan of how to try and fix it, but actually how to do the musculoskeletal rehab, that's a physio's job. And that's what they actually need more than anything.
Yeah. So as we come to the end, Gandhi, I think just giving a list of things that people perhaps might want to do in the next 2 weeks, before these deadlines.
So I think there's a couple of key actions, absolutely. The first one is have that introspective look at your practice as to what capacity you have, and let your system leaders, your PCM, clinical directors, your locality teams, or whatever they're called, aware of if you do have any extra capacity, because it's a fairly quick turnaround. I think the second one is the deadline in terms of the 28th of October.
I think people, as you said, sort of just review how you're approaching the appointment system internally, because you're going to be asked what you're going to be doing about these issues by the locality teams at some point. And then I would expand that conversation to the primary care network level. It's a good way of comparing notes about how open other practices in the areas are or not. Not everyone within a primary care network might be doing the same thing, so just see where you sit as a practice in terms of that. You can compare notes on staff availability, perhaps have some of these ad hoc digital locum, kind of services or provision for shifting staff around the primary care network, which I think needn't be as complicated as you could make it, to be honest. Maybe start exploring the digital locum services, things like that. Start having your conversations with the pharmacists. And also scope the assets. So there's some funding available, isn't there? So if you've got an old telephone system, just be really ready to put your hand up quickly and say, we would benefit from one of these online, digital web-based telephone systems. Can we have one, please? And there might be other things that you might be able to stick your hand up and say, if we had this would really, really help with access. So sort of have a think about that. And there might be an opportunity to access estates for hot sites, I think. And those are the sorts of things I'd be doing over the next few days and weeks.
And I think the other thing I would recommend practices do is have, again, that introspective look as to how they plan on tackling further verbal and physical abuse in their practices. There is supposedly a 5 million pot of money that we didn't talk about in the document that is being assigned for the improved security of practices. Whatever that means. There's no direction, there's no detail, but there is some funds for that. But more importantly, that look that if you are continuing to have abuse coming from patients inappropriately, or most of the time it is inappropriate, how is your response to that going to be? Have that discussion in your practice. Make sure your reception teams are confident that there is going to be a response, because there should be. And if there isn't, this is the turning point. I would say to most of those practices that you need to have that discussion as to what you're going to do about it. Because actually it's on the agenda now, quite rightly.
And get ready, because 1 in 5 of the practices out there will be in the bottom 20%. In fact, it's multi-access. It's multi-axis. So you can be in the top 20% for one, but not others. So potentially all of us could be in the top. And there's more than 5 different categories. So all of us could be in the bottom 20% for something or other. So just get ready for the knock at the door, and be ready to have that conversation and hopefully shift that conversation to a productive, supportive place.
You can clearly see there's going to end up being a risk register, isn't it? The practices that are in the 5 categories are going to need significant support and help. You're going to have some practices that may be in 1 of 5, but they're still on the agenda, shall we say. Anyway, we hope you found this useful. Apologies, we've probably gone into a bit more detail than we planned, but absolutely we hope this has been effective in terms of helping to understand this really pivotal, I think, document in terms of how it's going to impact primary care and general practice in particular over the next few months. Would like to reinforce that unfortunately it's non-recurrent funding, so it raises the absolute question, once the funding's gone, what's going to happen next year? Because let's be honest, it ain't going to quieten down in any way, shape or form. It's still going to be chaotically busy and crazy and stuff. And obviously this doesn't pay any attention to that, but it focuses much more on the specific winter pressures and stuff. But as always, if you do have any comments or questions, we'd love to hear them. Apologise that we couldn't do this one live for you guys. It would have been a great one to do and hear your comments. Unfortunately, we're just so overloaded with everything else, and obviously no one was expecting this to come down. So
comment in the comment section,
absolutely,
below on YouTube or wherever you are.
We will try our best to answer them and then feed them back to the relevant people if we're able to and stuff. But yeah, absolutely. If you have found this useful, let us know. Absolutely, leave a like down below. And also comments are the things that help us understand how you're finding this useful and effective and stuff. Feel free to share it with other people. It is available in audio format only on the podcast, if that's a better way that you find it to listen for other people in the practice in particular. And as always, eGP Learning is here to help save you and your patients time by taking out your primary care and learning. And we'll catch you in the next episode.